Kidneys, Part 2. The filtrate quickly passes from the capsular space into the renal tubule, where its volume and solute composition are dramatically changed. The end result of tubular processing is urine. Sodium ions are the most abundant ions in the extracellular fluid, and sodium is also the most abundant ion in the filtrate. Tubular transport depends on the continuous activity of the sodium-potassium pumps, which move 2 ions of potassium into the tubule cell and return 3 ions of sodium to the blood. Water reabsorption is always passive, occurring by osmosis through specialized water channels called aquaporons. The proximal tubule is located in the cortex and extends from Bowman's capsule to the loop of Henle. Reabsorption in the proximal tubule is driven by the rate of sodium reabsorption by the sodium-potassium pumps in the basolateral membrane. 90% of this uptake occurs early in the proximal tubule by means of the SGLT2, which is one of the 2 key sodium glucose co-transporter proteins. The remaining 10% is absorbed in the late proximal tubule by means of the SGLT1. SGLT2 is the target of medications used to treat type 2 diabetes mellitus. Blocking the SGLT2 reduces the postprandial swings of blood glucose by causing urinary excretion of excess blood or excess glucose. The proximal tubule bicarbonate reabsorption is coupled to the hydrogen ion secretion and is made possible by the enzyme carbonic anhydrase. Carbonic anhydrase catalyzes the interconversions of carbon dioxide and water with the dissociated ions of carbonic acid. Proximal tubule secretion of organic anions and cations is responsible for renal clearance of many endogenous compounds and water-soluble drugs. The high rate of proximal tubule reabsorption decreases the filtrate volume by about 70%, while concentrating substances such as drugs that are destined for urinary excretion. This is a summary of the proximal tubule's transport. The descending limb of the loop of Henle is freely permeable to water and impermeable to solutes. So, as the filtrate passes through the descending limb, the water is reabsorbed by osmosis and solutes, which are trapped in the tubule and become more concentrated. The ascending limb of loop of Henle is impermeable to water, but it does have transport mechanisms for various ions, which include sodium chloride, potassium, and calcium. While the filtrate volume is not further decreased in the ascending limb, the reabsorption of salt results in the filtrate becoming increasingly dilute. The distal tubule is the shortest segment of the renal tubule. Electrolyte reabsorption is the primary activity of the distal tubule. The sodium chloride cotransporter is blocked by thiazide diuretics. Principal cells are the primary cell type in the connecting tubule and collecting duct, and these are target cells for the hormones aldosterone and vasopressin. Aldosterone stimulates increased production and insertion of sodium and potassium channels in the apical membrane, and it increases the activity of the basolateral membrane sodium-potassium ATPase. This increases sodium reabsorption and potassium secretion in this segment of the tubule. The proximal tubule's main functions are bulk reabsorption of solutes and water, secretion of major wastes and toxins, reduction of the volume of the tubular fluid by about 2/3. The proximal tubule processing is high volume without fine-tuning the concentration of the tubular fluid. The distal tubule and the collecting duct are sites where solute concentration of urine is refined and the urine volume is adjusted in response to the homeostatic needs of the body. The loop of Henle has two aligned functions: the reabsorption of 25% of filtered sodium and chloride, and the generation of the concentrated medullary interstitium, which then enables the formation of concentrated urine to conserve body water and fluid volume. It accomplishes both goals through the looped structure. The descending limb is primarily permeable to water, and the ascending limb is impermeable to water, but is able to move the sodium chloride from the lumen to the interstitial space. With acute tubule dysfunction, there will be retention of sodium chloride and water. There will be a failure of the bicarbonate reabsorption and hydrogen ion secretion. The blood levels of waste products will increase. Drugs that are renally excreted will build to toxic levels. And this will determine the necessity for dialysis to aid the kidney in removing waste products until the kidney is functioning appropriately. Blood flows through the vasa recta at a relatively slow rate, and the walls of the vasa recta are very permeable to water and solutes. Water and solutes freely move in and out of the blood along the entire length of the vasa recta. The production of concentrated urine depends on osmotic equilibrium between urine in the collecting duct and the concentrated medullary interstitium. The numbers show the osmotic strength at each location of the tubules and the interstitium. The factors contributing to the buildup of osmolarity in the medulla include movement of more sodium and chloride than water over the entire loop of Henle, the lack of water permeability of the ascending loop of Henle, vasopressin-dependent reabsorption of water and urea at the collecting duct, recycling of urea between descending and ascending loops of vasa recta, and urea reabsorption in the collecting duct. Under conditions of dehydration, vasopressin levels and collecting duct water reabsorption, shown with blue arrows, increase, resulting in decreased urine volume or antidiuresis and increased urine osmolality up to the maximum of 1200. When fluid intake is normal or high, vasopressin secretion is inhibited. Collecting duct water reabsorption is inhibited, and increased amounts of dilute urine are excreted. Water is added to the body through ingestion and cellular metabolism, and then removed by water loss, sweat, urine, and feces. To prevent fluid overload or depletion, the intake obviously must equal the output. The renal control of water excretion, regulated by vasopressin, is the main point of control of water retention or removal. Thirst is regulated by angiotensin II and blood osmolality. This is the main control of water intake. Hypotension and hypovolemia are linked to these compensatory responses. There's increased sympathetic vasoconstrictor activity and increased sympathetic outflow to the kidneys that stimulates renin secretion and renal sodium retention. Renin secretion is further stimulated by macula densa activation of the juxtaglomerular apparatus granular cells. There's increases in circulating renin that lead to angiotensin I and conversion to angiotensin II. Remember, angiotensin II increases vasoconstriction, stimulates thirst, tubular sodium reabsorption, adrenal aldosterone secretion, posterior pituitary vasopressin secretion, and promotes increased sympathetic activity. Aldosterone acts on the distal nephron structures to promote sodium reabsorption. The baroreceptor signaling of hypotension is also linked through the neuropathways to increase pituitary vasopressin secretion, reinforcing the actions of angiotensin II. Vasopressin acts on the distal nephron to promote water reabsorption. All of these responses promote water acquisition through thirst, water retention, and sodium retention, therefore restoring the extracellular fluid volume and blood pressure over the long term than the rapidly acting baroreflexes. States of fluid and volume overload are less common than fluid and volume deficit. Upon ingestion of a large salty meal accompanied by a large beverage, the extracellular fluid volume will transiently expand. This would suppress the RAS and vasopressin secretion and increase secretion of atrial and B-type natriuretic peptides. The natriuretic peptides, these cause vasodilation to reduce blood pressure. They act to suppress sodium reabsorption in the distal nephron, leading to natriuresis and diuresis. Kidney disease includes acute kidney injury, which is often reversible, but not always, and chronic kidney disease, which has stages that it progresses through until ending at stage 5, which is also known as end-stage renal disease. So AKI is a complication of critical care, with sepsis being the most common cause. AKI is defined clinically by a rise in serum creatinine or a decrease in eGFR with changes in urine output. Pre-renal kidney damage results from inadequate renal blood flow. Post-renal kidney damage results from obstruction within the renal tubular system, the ureters, bladder, or the urethra. Intrarenal kidney damage can result from a pathological dysfunction of the glomerulus, tubule, interstitium, or renal vasculature. AKI is managed with fluid replacement, correction of any acid-base imbalances, or alkalinization to assist with clearance of a toxic substance, and dialysis sometimes. AKI does predispose to later development of chronic kidney disease. The hallmark of acute or chronic kidney dysfunction is an increase in blood levels of urea, so that's blood urea nitrogen, and creatinine. This indicates the loss of clearance functioning of the kidneys. mGFR, not estimated, but the laboratory measurement, is considered the gold standard of GFR measurements. And iohexol is used to determine the glomerular clearance. Either AKI or CKD can have manifestations of altered kidney maintenance of fluid and electrolyte homeostasis, including hypertension, edema, and acidosis. The standard BUN level is 6 to 24 milligrams per deciliter. When considering chronic kidney disease, one also needs to consider other disease processes or comorbidities, including diabetes and hypertension, because both of these can accelerate kidney disease in individuals. The final common pathway to progressive CKD involves loss of glomerular function and the pathological appearance of glomerulosclerosis, which is a scarring and loss of surface area of the glomerular capillaries. Also, there is capillary volume shrinking in Bowman's space. Tubular atrophy ensues as the glomerular function is lost and tubule cells undergo apoptosis. Interstitial fibrosis is fibrotic tissue that does replace some of the kidney tissue after nephron death. There is a relationship between CKD and cardiovascular disease. And most patients in stages 3 and 4 are more likely to die of cardiovascular disease than end-stage renal disease. Dyslipidemia is common in CKD and could be a predisposing factor in the cardiovascular mortality risk. A is a normal appearance of glomerulocapillary surrounded by basement membrane and podocytes foot processes separated by small infiltration slits. In B, there is podocyte damage that initiates degenerative changes. The foot processes are effaced, exposing glomerular basement membrane, which forms abnormal attachment to the parietal epithelial cells lining the Bowman's capsule. The PEC's deposit matrix on the outside of the glomerular capillary, while the mesangial matrix expands within the capillary. The capillary fills with hyaline fluid and foam cells as seen in C. The glomerular capillary then collapses with fibrotic changes, and the surface area for glomerular filtration in this loop is completely lost, contributing to an overall decrease in the glomerular filtration rate seen in D. Glomerular sclerosis pathology often starts with podocyte injury that breaks down the nephrons, causing them to degenerate. Beginning at stage 4 and continuing through stage 5, the CKD fluid and electrolyte homeostasis becomes progressively disordered, and the individual will need regular dialysis treatments. Anemia is very common, resulting from shorter red blood cell lifespan and a decrease in erythropoietin. Hypertension and metabolic acidosis are common. Chronic kidney disease, mineral and bone disorder is associated with a dysregulation of calcium and phosphate metabolism that is characterized by hyperphosphatemia and an elevated parathyroid hormone. This results in bone demineralization to help maintain normal blood calcium level, but it will make the patient predisposed to bone fractures. Americans with African ancestral descent have a greater prevalence of end-stage renal disease. They are more likely to have advanced kidney disease and are more likely to also be on dialysis. Acute post-streptococcal glomerulonephritis can follow a respiratory or a skin infection. These patients will usually present with hematuria and hypertension. Autosomal dominant polycystic kidney disease is the most common disorder of renal structure and function. The kidneys begin to decrease in weight and volume beginning about the 4th decade of life. Each decade after age 40, the renal blood flow is reduced by about 10%, and the average GFR decreases by 8 milliliters per minute per 1.73 meters squared. The reduction in both GFR and renal blood flow are interconnected and primarily involve structural changes within the kidney and its vasculature. So also at about age 40, the number of nephrons begin to decrease by more than 6,000 per kidney per year. This helps to explain the decrease in the renal blood flow and the GFR. Hyaline arteriosclerosis of the afferent arterioles can also reduce glomerular blood flow and can become severe enough to lead to shunting of blood from the afferent to the efferent arterioles, completely bypassing some of the glomeruli. Glomerulosclerosis contributes to age-related nephron loss in combination with arteriosclerosis, tubular atrophy, and interstitial fibrosis. Tubular atrophy and interstitial fibrosis are likely the final steps in nephron death and are preceded by glomerular collapse. Tubular atrophy is evident by overall loss or collapse of the visible tubules in biopsy specimens. The reduction in nephron number and GFR impacts the renal drug clearance in older adults.